Welcome. In this session, we'll be discussing about retinal disorders from hemoglobinopathies such as sickle cell disease and coagulopathies such as disseminated intravascular coagulation and thrombocytopenic purpura. Sickle cell disease is characterized by intravascular thrombosis, intravascular hemolysis, and deficient oxygen transport to the tissues. Sickle cell disease results from mutations in the gene for the beta globin unit of hemoglobin, and sickle cell disease can result from three genotypic states: HBSS, HBSC, and HBS beta thalassemia. In homozygous HBSS genotype, both alleles of beta globin gene are HBS, in which there is a mutation in the sixth position of the beta globin protein from glutamic acid to valine. 90% of hemoglobin in patients with HBSS genotype is hemoglobin S, and the remaining 10% of hemoglobin is fetal hemoglobin. And in contrast to other sickle cell genotypes such as HBSC and HBS beta thalassemia, HBSS genotype patients have severe systemic morbidity, but proliferative sickle cell retinopathy is uncommon in HBSS genotype as compared to the two other sickle cell genotypes. But acute severe retinal vascular occlusions are more common in HBSS genotype as compared to patients with other sickle cell genotypes. In the compound heterozygous HBSC genotype, one allele of beta globin gene is HBS and the other allele is HBC, which has a mutation in the same position of the beta globin protein but from glutamic acid to lysine. HBC allele is autosomal recessive like HBS allele and occurs commonly in the general population. In patients with HBSC genotype, 50% of total hemoglobin is HBS and the remaining 50% is HBC. As compared to patients with HBSS genotype, patients with HBSC genotype have less severe systemic morbidity but have a higher likelihood of proliferative sickle retinopathy from chronic hypoxia, because in HBSS genotype there is acute severe retinal vascular occlusions leading to retinal infarction, and it is said that infarcted retina does not produce angiogenic factors which cause proliferative sickle retinopathy. But in HBSC genotype, there is chronic hypoxia of the retina instead of infarction, and the hypoxic retina produce angiogenic factors to cause proliferative sickle retinopathy. So in sickle cell disease, severity of systemic symptoms does not match the severity of proliferative retinopathy in the eye. In the third sickle genotype, HBS beta thalassemia, one allele of the beta globin gene is HBS and the other allele is that of beta thalassemia, which can be one of more than 200 mutations which are typically autosomal recessive and cause reduced production or absence of the beta globin protein of hemoglobin. In HBS beta 0 thalassemia genotype, the beta globin protein is almost absent, and 90% of hemoglobin in patients with this genotype is hemoglobin S, and so the clinical course of these patients is similar to HBSS genotype patients. In HBS beta plus thalassemia genotype, beta globin protein production is reduced but not absent, and so in patients with this genotype, 60 to 95% of hemoglobin is hemoglobin S and 5 to 30% of hemoglobin is hemoglobin A or normal adult hemoglobin. So in comparison to patients with HBSS genotype, patients with HBS beta plus thalassemia genotype have less severe systemic disease but with a higher risk of proliferative sickle retinopathy, which we will be discussing. And of course, homozygous state of either HBC allele or HB beta thalassemia allele does not result in sickle cell disease. In contrast to sickle cell disease, in which both alleles for beta globin protein are abnormal, in sickle cell trait, one allele for beta globin protein is normal, but the other allele is that of hemoglobin S. Hemoglobin electrophoresis can differentiate between sickle cell trait and sickle cell disease, with 40% of total hemoglobin being abnormal in sickle cell trait and 90% or more of total hemoglobin being abnormal in sickle cell disease. Sickle cell disease is the most common inherited blood disorder worldwide, with approximately 3.2 million people having sickle cell disease with any of the three sickle genotypes. 43 million people have sickle cell trait, and these patients are usually asymptomatic except when under hypoxic stress. As in patients with sickle cell disease, patients with sickle cell trait can have raised intraocular pressure from high fever due to any cause and macular ischemia along with other comorbidities, but other ocular manifestations of sickle cell disease typically do not occur in patients with sickle cell trait, and this is very important to remember. Sickle cell disease is more common among blacks and Africans, and children and adolescents make up a large proportion of all sickle cell disease patients. Among the three sickle genotypes, HBSS is much more common than HBSC, and HBS beta thalassemia is even less common. But as we have already mentioned, and which we will further discuss, proliferative sickle retinopathy is much more common in HBSC and HBS beta thalassemia genotypes as compared to HBSS genotype, whereas acute severe retinal vascular occlusions are more common in HBSS genotype as compared to HBSC and HBS beta thalassemia genotypes. Pathophysiology of sickle cell disease is as follows. Hypoxia from any cause induces polymerization of hemoglobin S within the red blood cells, and this polymerization or aggregation of hemoglobin S transforms the red blood cells from a discoid shape, which is pliable and so can easily deform and pass through the capillaries, to a rigid sickle shape, which is elongated and crescentic and thus cannot pass easily through the capillaries, thereby blocking the capillaries and causing tissue hypoxia. The resulting hypoxia induces further sickling, resulting in a vicious cycle, and also induces VEGF secretion, which promotes neovascularization. And apart from hypoxia, inflammation, infections, acidosis, and dehydration may also induce or contribute to sickling. Systemic features typically occur in patients with HBSS genotype, but is much less common in patients with HBSC and HBS beta thalassemia genotypes, and a list of systemic features is given here. Anterior segment examination in a patient with sickle cell disease may show the conjunctival comma sign or segmental iris stromal atrophy. The conjunctival comma sign consists of isolated saccular or short linear dilatations of small conjunctival blood vessels due to segmentation of blood, as seen here in this clinical photograph. They are more common in inferior bulbar conjunctiva and inferior fornix, and are more common in patients with HBSS genotype and during hypoxic stress. They become more prominent after application of vasoconstricting eye drops such as those found in pupil dilators and are relieved by heat from the slit lamp. And this clinical photograph shows segmental iris stromal atrophy in a patient with sickle cell disease. Raised intraocular pressure from high fever due to any cause, either post-operative or post-traumatic, is a vision-threatening emergency in both sickle cell disease and sickle cell trait, and this is very important to remember. Acidic pH and low oxygen tension in the anterior segment induce sickling of RBCs in the anterior chamber, which clog the trabecular meshwork. And even mild to modest IOP elevation in patients with sickle cell disease slows blood flow and induces sickling in vessels supplying the retina and the optic nerve. Also, IOP lowering with hyperosmotic agents, carbonic anhydrase inhibitors, and alpha-adrenergic agonists should be avoided in patients with sickle cell disease because hyperosmotic agents cause hemoconcentration, carbonic anhydrase inhibitors cause acidosis, and alpha-adrenergic agonists cause vasoconstriction, all of which may promote sickling. And in this situation of raised intraocular pressure from hyphema in a patient with sickle cell disease, early paracentesis or tissue plasminogen activated injection is recommended. Neovascular glaucoma rarely occurs in patients with sickle cell disease, and scleral discoloration from jaundice, as seen here in this clinical photograph, can occur due to hemolysis in patients with sickle cell disease. In the peripheral retinal vasculature, peripheral retinal arteriolar occlusion and arteriovenous anastomosis formation is typical in patients with sickle cell disease. Peripheral retinal arteriolar occlusion may start either at the capillary level and progress in a retrograde manner into the arterioles, or may occur at arterial bifurcations. And peripheral retinal arteriolar occlusion typically occurs most commonly in the peripheral temporal retina in patients with sickle cell disease, but venous occlusion is uncommon in these patients. This fluorescent angiogram shows peripheral retinal arterial or occlusions, resulting in termination of dye transit prior to reaching the extreme peripheral retina. Arteriovenous anastomosis, as seen here in this fluorescent angiogram, are dilated pre-existing capillaries which connect occluded arterioles with adjacent terminal venules at the junction of perfused and non-perfused retina. Arteriovenous anastomosis do not leak on fluorescent angiography. Occluded peripheral retinal arteries may appear white, which is called the silver-wearing appearance of these blood vessels, and venous tortuosity, as seen here in this clinical photograph, can occur in sickle cell disease. Choroidal infarcts can occur from an acute occlusive event but is uncommon in patients with sickle cell disease. The three clinical signs of non-proliferative sickle retinopathy are salmon patch hemorrhage, iridescent spots, and black sunbursts. Salmon patch hemorrhage, as seen here in these two clinical photographs, are subinternal limiting membrane hemorrhage adjacent to an area of retinal ischemia and its occluded arteriole, and is said to occur from bursting of the occluded arteriole. It initially appears red but later transforms into an orange or salmon color due to hemolysis, as seen here in this clinical photograph. The blood in the subileum space may remain in the subileum space or may migrate into the vitreous cavity or the subretinal space. Iridescent spots, as seen here in this clinical photograph, occur following reabsorption of the subileum hemorrhage when the subileum schisis cavity is occupied by hemosiderin-laden macrophages which appear refractile. Black sunbursts, as seen here in this clinical photograph, are flat, stellate or ovoid areas of pigmentation due to focal RP hypertrophy, hyperplasia or pigment migration into the retina. Black sunbursts can occur from either subretinal migration of subileum blood or from choroidal ischemia. Since these non-proliferative lesions usually occur in equatorial or pre-equatorial retina, they do not affect visual acuity. Proliferative sickle retinopathy or PSR is characterized by the development of typical peripheral retinal neovascularization resembling a CFAN, as seen here in this clinical photograph. In contrast, neovascularization in diabetic retinopathy typically occurs posterior to the equator. PSR is detected most commonly in the third or fourth decades of life in patients with sickle cell disease, but may be found as early as first decade. The CFANs are most commonly found in the superotemporal quadrant, followed by inferotemporal, supraronasal, and inferonasal quadrants in a decreasing order of frequency. The CFANs are typically found at the junction of ischemic and non-ischemic retina, as seen here in this clinical photograph, and are said to arise from arteriovenous crossings and arteriovenous anastomosis, and from there they tend to grow further peripherally towards the ora serrata, as seen here in this clinical photograph. Being neovascular lesions, these CFANs of sickle cell disease show profuse leakage of dye on fluorescent angiography, as seen in these two fluorescent angiograms. An ultra-wide field fluorescent angiography is particularly useful in eyes with proliferative sickle retinopathy because of the far peripheral location of these CFANs. With time, these CFANs develop multiple feeding retinal arterioles and draining retinal venules, as seen here in this fluorescent angiogram. This is an ultra-wide field fluorescent angiogram showing a peripherally located CFAN and the macula in one single frame. Proliferative sickle retinopathy is the major cause of vision loss in patients with sickle cell disease because the CFAN can lead to vitreous hemorrhage, tractional or combined retinal detachment, or tractional retinoschisis. Resolving vitreous hemorrhage may appear as ochre-colored membranes within the vitreous cavity, and retinal tears usually occur at the base of a CFAN, as seen here in this clinical photograph, due to stretched retinal holes occurring within thinned out non-perfused retina as a result of traction. Unlike in proliferative diabetic retinopathy, where the tractional retinal detachment is predominantly posterior to the equator, the tractional retinal detachment in sickle cell disease occurs predominantly in the periphery anterior to the equator. And it has been found that 10 to 12% of untreated eyes in patients with sickle cell disease lose vision within 10 years of diagnosis of sickle cell disease. As we have mentioned, Non-proliferative sickle cell retinopathy occurs more frequently in patients with HbSC and HbS beta thalassemia genotypes as compared to patients with HbSS genotype, and this is very important to remember. And risk factors for developing PSR include age and factors which promote sickling, such as high hemoglobin levels, high MCV, high MCHC, and low HbF levels. Autoinfarction and spontaneous regression has been found in almost one-third of CFANs and is said to occur due to vasoocclusion due to sickling within the CFAN itself. It occurs more commonly in patients with HbSS genotype and results in residual grayish-white fibrous tissue, often with patent blood vessels at their base. This photograph shows a partially regressed CFAN, and this photograph shows an almost completely regressed CFAN. Goldberg staging system of proliferative sickle retinopathy consists of 5 stages, with stage 1 referring to peripheral retinal capillary occlusion, stage 2 referring to arteriovenous anastomosis, stage 3 referring to CFAN retinal neovascularization, stage 4 referring to vitreous hemorrhage, and stage 5 referring to retinal detachment. In addition to peripheral retina, the central macula can also be involved in sickle cell disease, and sickle cell maculopathy occurs due to ischemia and thinning of the inner retinal layers. Sickle cell maculopathy occurs in almost half of all SCD patients, with equal prevalence between HbSS and HbSC genotypes. Clinical and diagnostic features of sickle cell maculopathy may not correlate with visual acuity, except when paracentral acute middle maculopathy occurs, which can be correlated with decreased visual acuity, but the features of sickle cell maculopathy may cause decreased contrast sensitivity, color vision abnormalities, and scotomas. In sickle cell maculopathy, the foveal reflex clinically appears as an enlarged or eccentric depression, which is called the macular depression sign, as seen here in this clinical photograph. Fluorescein angiography in eyes with sickle cell maculopathy shows an enlarged foveal avascular zone with telangiectatic vessels at its margins, as seen here in this fluorescein angiogram. OCT in eyes with sickle cell maculopathy shows thinning of the inner and middle retinal layers, particularly in the temporal retina, as seen in this OCT in a patient with sickle cell disease in comparison to this OCT in a normal individual. This temporal thinning of parafoveal retina predicts the possibility of proliferative sickle retinopathy in retinal periphery and indicates the need for fluorescein angiography or ultra-wide field fluorescein angiography to detect the latter. Splaying, that is broadening or saucerization of foveal depression, is characteristic of eyes with sickle cell maculopathy and can be discerned when compared to a normal foveal contour. This OCT also shows temporal thinning of the macula, but further away from the fovea. Paracentral acute middle maculopathy, which we have discussed in earlier sessions and as seen here in this OCT, can occur following acute vasoocclusion in retinal capillaries and is associated with decreased visual acuity. These two fundus photographs belong to a patient with sickle cell disease showing grayish-white patches of PAMM nasal to the fovea in either eye, and this is the OCT scan of the right eye showing PAMM nasal to the fovea and the characteristic temporal macular thinning of sickle cell disease. And sickle cell maculopathy eyes also show abnormalities on multifocal ERG. Dilated capillaries appearing as small red dots may be detected on the optic nerve head, as seen here in this red-free photograph, but neovascularization of the optic disc occurs rarely in sickle cell disease. Angioid streaks are found in 1 to 2% of patients with sickle cell disease and occurs most commonly with the HbSS genotype, but angioid streaks in patients with sickle cell disease rarely cause choroidal neovascularization. Orbital involvement in patients with sickle cell disease is uncommon but is important to recognize to save vision. Bone infarction and orbital hematoma can cause orbital compartment syndrome, characterized by fever, facial pain, lid swelling, proptosis, restriction of ocular movements, and loss of vision due to compressive or ischemic optic neuropathy. In this situation, supportive therapy is required to reverse the sickling crisis, and steroids and occasionally orbital decompression are required. Hemoglobin electrophoresis and genetic testing can differentiate between the 3 sickle genotypes. but sickling or solubility test cannot differentiate between the three sickle cell disease genotypes and also cannot differentiate between sickle cell trait and sickle cell disease. Differential diagnosis of peripheral retinal neovascularization include acquired vasculopathies like proliferative diabetic retinopathy and retinal vascular occlusions, hereditary vasculopathies such as familial exudative vitreoretinopathy, incontinentia pigmenti, and sickle cell retinopathies, inflammatory diseases such as retinal vasculitis, and miscellaneous conditions such as choroidal tumors, chronic retinal detachment, and retinoschisis. Indications for treatment in proliferative sickle cell retinopathy include rapidly progressing CFAN, large elevated CFAN, non-clearing vitreous hemorrhage, tractional retinal detachment, and bilateral disease. Small flat CFANs usually do not cause vitreous hemorrhage and undergo autoinfarction and may not need treatment. Scattered laser photocoagulation and anti-VEGF injections are indicated for CFANs with limited vitreous hemorrhage. Laser should be performed cautiously as induction of retinal tears with the laser can occur and is more common in proliferative sickle retinopathy as compared to proliferative diabetic retinopathy. Anti-VEGF injections can be used prior to vitrectomy in eyes of patients with sickle cell disease, and this reduces the risk of intraoperative hemorrhage and makes surgical dissection easier. Vitrectomy is required for non-clearing vitreous hemorrhage and retinal detachment, but there are certain precautions which need to be taken during surgery, and this is important to remember. These include maintaining adequate oxygenation and hydration, avoiding vasoconstrictors in local anesthetics and pupil dilating drops, avoiding increasing intraocular pressure to control intraoperative hemorrhage, and herein lies the importance of preoperative anti-VEGF injections, preferring segmentation instead of delamination, which may create iatrogenic holes in atrophic ischemic retina. We have discussed about segmentation and delamination in the session on proliferative diabetic retinopathy. Scleral buckling should be performed carefully to prevent anterior segment ischemia, and post-operatively intraocular pressure, oxygenation, and hydration should be monitored. The recommended screening protocol for proliferative sickle retinopathy is as follows. Sickle cell disease patients should undergo a dilated retinal examination at 10 years of age, followed by at least annual re-examinations. And as we have mentioned, OCTA is recommended during screening because flow deficits detected in temporal macula on OCTA correlates with peripheral non-perfusion, indicating the need for fluorescent angiography or ultrawide field fluorescent angiography to detect peripheral non-perfusion as well as CFAN neovascularization. Also, flow deficits on OCTA has been found to precede detection of thinning of macula, which is characteristic of SCD eyes on OCT. The systemic coagulopathy syndromes are characterized by hypercoagulability and susceptibility to bleeding, and they include DIC, TTP, ITP, and AGLLP syndrome. The ocular features of systemic coagulopathy syndromes are similar and are so considered together. Ocular manifestations in systemic coagulopathy syndromes occur due to both ischemia from platelet fibrin thrombi and also due to hemorrhage from thrombocytopenia and anemia. Choroidal circulation is more commonly affected than retinal circulation in systemic coagulopathy syndromes, and this is important to remember. Choroidal vascular occlusion clinically appear as yellowish placoid areas, and they can be either L-Schnick spots, Sigrist streaks, and amalgam triangles, which we have discussed in the session on hypertensive retinopathy. And RP destruction due to choroidal ischemia leads to subretinal fluid accumulation and exudative retinal detachment, as seen here in these two clinical photographs from the two fundi of a patient with thrombotic thrombocytopenic purpura. Following resolution, pigmentary alterations of retinal pigment epithelium occur. Fluorescent angiogram shows patchy reticular areas of choroidal filling defects, as seen here in this angiogram, with bordering areas of hyperfluorescence, and in later phases of the angiogram, leakage of dye will be found in areas of RP damage, as seen here in this angiogram. Choroidal filling defects will also be apparent on indocyanine green angiography, and OCT will show subretinal fluid when exudative retinal detachment occurs, and OCTA will also show flow deficits in the choriocapillaries. Retinal vascular occlusion is rare in systemic coagulopathies, and may present as retinal arterial occlusion, retinal vein occlusion, or posterior retinopathy, as seen here in the two fundi of a patient with thrombotic thrombocytopenic purpura. Hemorrhages may occur as intraretinal dot blot hemorrhages to larger sub-RP and subretinal hemorrhage as well as vitreous hemorrhage, but choroidal hemorrhage is uncommon. Anterior segment involvement in systemic coagulopathies is rare except for the occurrence of subconjunctival hemorrhage. Vision loss from choroidal ischemia is usually permanent, but vision loss from subretinal fluid and hemorrhages may reverse at least partially following resolution of the systemic coagulopathy. Differential diagnosis includes hypertensive retinopathy, but hypertension may coexist in patients with systemic coagulopathies because of renal involvement. Systemic inflammatory disorders such as systemic lupus erythematosus and giant cell arteritis may also present with choroidal ischemia, and placoid disorders such as APMPP and choroidal ischemia following photodynamic therapy may resemble choroidal ischemia in systemic coagulopathies. To recap, sickle cell disease results from three genotypes: HBSS, HBSC, and HBS beta thalassemia, all of which results from mutations in the beta globin chain of hemoglobin, which result in sickling of red blood cells, especially under conditions of hypoxia, acidosis, and hemoconcentration, resulting in microvascular occlusion and intravascular hemolysis. HBSS genotype can have more severe systemic complications as compared to the severity of proliferative retinopathy, while HBSC and HBS beta thalassemia genotypes typically have more severe proliferative retinopathy as compared to the severity of the systemic symptoms. Sickle cell disease usually presents in childhood or early adulthood. Anterior segment examination can show isolated dilated segments of conjunctival vessels, which is called the coma sign, particularly during hypoxic stress, iris stromal atrophy, and raised intraocular pressure from hyphema, which may occlude blood vessels supplying the retina and the optic nerve. Neovascularization in proliferative sickle cell retinopathy is rare. Posterior segment examination may show peripheral arteriolar occlusions with peripheral retinal non-perfusion and arteriovenous anastomosis, which do not leak profusely on fluorescent angiography at the junction of perfused and non-perfused retina. These findings are more easily detected on fluorescent angiography. Non-proliferative sickle cell retinopathy is characterized clinically by Salmon patch hemorrhages, iridescent spots, and black sunbursts. Proliferative sickle cell retinopathy is characterized by development of peripheral neovascularization at the junction of perfused and non-perfused retina, which leak profusely on fluorescent angiography and are more easily detected on ultra-wide-field fluorescent angiography. CFAN neovascularization can lead to vitreous hemorrhage, tractional combined retinal detachment, or may undergo autoinfarction, leading to residual grayish-white fibrous tissue at the site of the original CFAN. Macula may show replacement of a normal foveolar reflex with an ovoid depression called the macular depression sign, and can show splaying of foveal contour on OCT. OCT typically shows thinning of the inner layers of the retina temporal to the macula, which predicts the presence of peripheral non-perfusion, which should be searched for with ultra-wide-field fluorescent angiography. OCTA shows flow deficits in the region of macular thinning. Fluorescent angiography shows an enlarged foveal avascular zone with telangiectatic vessels at the margin of the foveal avascular zone. Optic disc may show isolated capillaries as small red dots on its anterior surface. Orbital involvement due to infarction of orbital bones or orbital hematoma may present as proptosis and may cause orbital compression syndrome. Large elevated CFANs require treatment by scattered laser photocoagulation to the non-perfused retina and or anti-VEGF injections. Non-clearing vitreous hemorrhage and tractional retinal detachment require vitrectomy, but several intraoperative measures need to be taken to avoid intraocular pressure increases, hypoxia, and ischemia of ocular structures. SCD patients should be screened for ocular features of sickle cell disease initially at 10 years of age and then at least once annually. The systemic coagulopathy syndromes present with similar ophthalmic signs. The choroidal circulation is most commonly affected, which may manifest as serous retinal detachment due to RPE damage, delayed choroidal filling on fluorescent angiography and indocyanine green angiography, leakage on fluorescent angiography at sites of RPE damage, serous detachment on OCT, choriocapillaris filling defects on octa, and pigmentary changes following resolution of the underlying disease. Retinal vascular occlusions are less common in patients with systemic coagulopathies, but retinal and subconjunctival hemorrhages can occur. Thank you for listening.